system, which may then further fuel the folks that I see behind bars in Canadian penitentiaries. So, how's that for a welcoming sight? If you weren't depressed before, how might you feel if this was now your home? The physical conditions of penitentiaries, the Canadian penitentiaries on average are about 40 years old. Some of them are more than 3 times that old. Kingston Pen is over 150. Prisons are not typically built to be pleasant. They're not airy, they're not light. They're often very crowded, they're chaotic, they're noisy. Not therapeutic environments in many ways. And prisons are all about control. Behavior is to be controlled. And so people who have some mental health issues, sometimes their behavior doesn't look like it's under control. What typically happens in a prison is that the response is all too often an attempt to impose order. So it's typically you get a security-driven response. The conflict between security and treatment, or security and programs, or security and intervention, is a time-honored conflict in corrections. It's a very difficult decision to make. The first responders inside a correctional system setting are typically security staff, prison guards. They have a whole host of responsibilities. If somebody's in an acute phase of their illness and they're decompensating and their behavior gets difficult, those correctional guards, those staff, they may not have the tools, they may not have the backup. Depending on the time of day or the day of the week, there may not be any medical people available inside that institution that they're working in. There may not even be a nurse around. We have medium security penitentiaries with 400 or 500 people in them. And depending on the shift, you may have fewer than 15 staff. If there's a crisis, you want to get it under control real quick. So it's a real issue. Now, the Correctional Service of Canada knows that it's a real issue, and they've gone to the government over the last few years, and they've been successful in getting about $60 million in dedicated funding to help address some of the mental health issues in federal penitentiaries. So starting in about late 2004, they received almost $30 million for their community mental health initiative. Now I must say this actually puzzled me. And it's not that the community mental health initiative is negative, it's not. It's a very good initiative. But what happened in 2004 is the Correctional Service of Canada produced the outline of a strategy for dealing with mental health. And they said, here's all of the things we have to do. We have to do a better job of assessment. We have to do a better job of triage. We have to do a better job of providing services. We have to hire more healthcare professionals. We have to build better linkages with the community. We have to build better rapport with health providing systems. And then we have to do a better job of dealing with continuity of care and transferring people when they leave the institution and at warrant expiry or whatever in the community. So they identified all those things. And then the very first initiative that they said they needed that they were going to work on was that piece when they were being released from the institution. And I often wondered about that. Like, wouldn't you start with assessment first, or wouldn't you start someplace else? But anyway, the Correctional Service of Canada decided in their wisdom that they were going to spend their first money on the release side, and they did. And as you say, good initiative. Things have gotten a little bit better. And British Columbia, actually, in this region, actually was leading the country in that. Then they got about another $20 million for the institutional side, all of those other things that I was talking about. And then they got some permanent annual funding. And so with all of that new money, they've done this, like that computerized screening and assessment, that March 2010 slide that I showed you where we found out about the prevalence rates. They got all that as a result of this new funding. So there is now much better screening, much better assessing. They've put some effort into recruiting and retaining healthcare professionals, although there's still big gaps there. And so the government has actually responded to the correctional service identified need and has given them this $60 million. But it's not necessarily hitting all the right buttons. We know that offenders inside federal penitentiaries with mental health issues are still undercounted. We know that even with all the new screening, we know that there are issues about not screening appropriately for traumatic brain injury, for people dealing with brain injury, with FASD. We know that people with cognitive impairment are not well screened. We know that there are issues with the timeliness of the screenings and assessment and the frequency. As people are aging, the number of offenders aged over 50 inside federal penitentiaries has grown by 50% in the last 10 years. Now, over 50, please don't be offended, over 50, I'm 53, so over 50 you become elderly inside a penitentiary. Inside a penitentiary, you age much quicker in a penitentiary. And your lifestyle, typically, before you were incarcerated, was very rough on you. So starting at age 50, we begin to see all kinds of age-related problems, including early onset of Alzheimer's, dementia, significant memory loss, hearing loss, vision impairment, let alone all of the physical mobility issues. So all of the assessment that's being done is great, but it's missing some big and important segments of the population and missing some of their issues. So this is, there's a couple things about this photograph that I find fascinating. This is a brand new unit that's been built at a regional psychiatric center. In fact, the one here in British Columbia. There's 5 regional psychiatric centers run by the Correctional Service of Canada, one in each region. And these are hospitals. These are prison hospitals. These are for people who are acutely ill. And you're sent to one of these places to be stabilized, and then you return to your parent institution. That's the idea. One of the things that we've noticed is a big gap in how the Correctional Service of Canada responds to mental health issues is that we don't see a lot of what we call intermediate care. So they do a lot of the immediate intervention, primary care stuff pretty well. They've got these acute care hospital beds, about 600 or 700 of them scattered across the country for the people who are very ill and need that. But they don't have a lot of what we call intermediate care, something in the middle, something to help you transition maybe back from one of those forensic centers into your parent institution, or something that you can go to for a little bit of time so you wouldn't have to be transferred to one of those 5 regional hospitals. And also, not a good resource for people who chronically self-harm. The incidence of self-harm in penitentiary is escalating. It's particularly bad for women. One of the intermediate care issues is dealing with people who chronically self-harm, and particularly who self-harm as a response to their incarceration. They're self-harming in response to their lack of control in their environment, as opposed to any other underlying mental health issue. So the Correctional Service of Canada acted on one of our recommendations, and they're piloting this new complex needs unit at this forensic center in BC. There it is, the complex needs unit. It's a purpose-built unit, 12 beds, national resource. So for the 12 hardest to manage, chronically self-harming inmates, male inmates in Canada, they will be moved to this new facility, this new resource called the complex need unit. So I went on a tour of the complex needs unit. I'm very impressed with their staffing model. I'm very impressed with their clinical plan. I have some issues about it being in the Pacific region and only being 1 and 12 beds and some other operational questions. And then they sent me this photograph. And can any of you guess what the first thing I noticed was?
Stark.
Well, it's actually pretty well appointed for a prison cell.
Yeah.
But yeah, it's pretty barren.
The lighting.
Yeah.
A single puddle.
Taken from the bathroom.
Now, okay, I'm a trained investigator, right?
That's a shock.
First thing I noticed was the bulletin board. I'm thinking, this is a cell for somebody who chronically self-harms. What are they going to use to put stuff up on the bulletin board? I mean, I asked, I said, what's the bulletin board for? They said, well, they were there. These are older cells, and the bulletin boards were there, and they never thought about it. But that was actually, anyway, that's just strange. It's the first thing I noticed is that they had bulletin boards.
Are they
Yeah.
still there?
Yeah, they are, but they're still not giving them push pins. This is a pretty stark environment. But it's actually bright and airy compared to some. It has a full-size window, it's got natural light. It's a pretty safe environment. I don't see any really obvious suspension points. If you were to tie off a ligature here, it's possible. This is breakaway, so you probably couldn't hurt yourself too badly there. There's no exposed wiring, conduit, sprinkler heads. Believe it or not, in 2011, when I review a death in custody, a death by hanging, I am still making recommendations about removing suspension points from cells. We'll have 10, 12, 15 suicides this year in federal penitentiaries. At least half of those will be by ligature. And I'm still making recommendations to remove suspension points from cells. Anyway, that's the complex need unit. So, speaking of deaths in custody, some of the lessons that we've learned, and we've actually done a couple of studies. One, we used some data in cooperation with the BC Coroner Service. That study is about to be published. Can't remember the journal, but the lead author's name is Winterdyke, if you want to look for that. But these are some of the things that we've noticed. Information sharing. We had a conversation at dinner about information sharing and how sometimes people misunderstand or misuse privacy legislation when it comes to sharing or not sharing of information. We see significant challenges inside a prison between one part of the prison and another part of the prison openly sharing information that would be in the best interest of the inmate/patient to share. Lots of transfers. In the Ashley Smith case that Herschel referred to, Ashley Smith entered the federal system after her 18th birthday. She spent 11 and a half months inside federal penitentiaries. In the 11 and a half months, she was moved or transferred 17 times. Hard to establish a therapeutic relationship with a care team if you're moved 17 times. 17 times in 11 and a half months. And when we looked at it, we looked at the policy around transfer. And what we found is that the policy was routinely ignored.